I probably won't either. Hey guys.
Okay, welcome back. You all came back. You have your seats, but whatever. So it's really nice lecturing to a small, intimate group because we have 200 in the class. So this is a real joy. Again, I couldn't get Turning Point to work, so we're going to have some questions, but we'll answer them by hand, and they're all at the end. And the other thing is the slides are supposed to be posted, and I really try to connect the slides with the handout. And before I move on the other handout that was posted, slides that was posted at the end, there's a reference of a medical letter, gout review article in Medical Letter from March. It would really be beneficial for you to pull that. It contains all the adverse effects and a nice review of the drugs. So it'll be really helpful to review. It also has my cell phone on it, number. If you want to reach me, feel free to call me. Or text me, just say who you are, or email me is best. And there's my email address. All right? So our learning objectives are posted on your handout. And basically what I want to do in 1 hour or less is to help you learn what the most effective therapy plan is for a patient and what key points you have to be aware of. You can see there's a lot of drugs. You need to be aware of these. I'm going to focus on the key drugs, but obviously as a pharmacist we need to know all the drugs. For the exam, I'll tell you which ones to focus on. So we're going to use non-steroidals, we're going to use steroids, but we're going to use primarily what are called DMARDs. DMARDs are disease-modifying agents. And you, as a pharmacist, are going to be able to provide the appropriate education to the patient on these drugs. So first of all, what is RA? RA is also a disease similar to gout that we talked about yesterday. There's many different kinds, arthritis, and there can be different manifestations in that a patient can have a flare-up and have an inflammatory response. They can just have it in their joints, or you can have extra-articular manifestations, which we'll talk about shortly. And the other thing is you'll see specific lab findings in patients, and they will have positive rheumatoid factor, they will have erosions in their bones and joints, and they can also develop osteoporosis. So we really have to stick to treatment. We will never be able, we can have juvenile rheumatoid arthritis that starts out in children. I'm not going to touch upon that, but the juvenile or the adult form of RA really requires long-term therapy. It's an autoimmune disorder. So, this first question is, the primary thing is we never use long-term therapy of NSAIDs. So choice B is incorrect because we're going to use NSAIDs only to relieve pain, and we'll use those intermittently. RA occurs in a lower number of patients compared to RA. Our OA is much more common than RA. And so the first point, choice A, is correct. It's typically, RA occurs in children through adults, so there's a spectrum. It starts out in kids, but adults can develop it as well. And most commonly, the adults that you get RA during your years of 20 to 30 years of age, and then there's a spike later on at 50 to 60. So it's a systemic inflammatory autoimmune disease. The body basically, different things in the body are attacking itself. And they're not sure why it occurs or what the cause is, but there are multiple factors. There's a genetic susceptibility in that if you have a certain marker, which is the HLA-DR4 antigen, you have a 2/3 chance of developing that. And it's present in some patients, but not all. There is a more commonly occurs in women, 2 to 4 times more common compared to gout, which was more common in men. And the general age of onset starts at 15 and goes up to 45. And the other thing is there is a long-term impact on the patient's health. And it often, if not treated, will lead to permanent disability, and you will require joint replacement. So there's a lot of theories about why it occurs. I'm going to spend a little bit of time on the pathophysiology and these theories because we're going to use specific drugs that are going to reverse these mechanisms, all right? So the first thing, we have something that triggers this in genetically susceptible individuals. And this autoimmune process involves the T cells and the B cells. So we're going to be using drugs that act upon these T cells and B cells. And this inflammation is in the synovial fluid, in the synovial joints. And what we see is secretion by the macrophages of interleukin-2, tumor necrosis factor, and prostaglandins. Those are the 3 key biomarkers that are released, and then you'll see others as well. And what happens is you'll have increased blood flow and permeability of the blood vessels, and this results in the synovial inflammation. And eventually, over time, if we don't reverse this, we're going to have joint damage. And the basic thing that happens is damage to the bones and damage to the cartilage. And this chronic inflammation will occur over time, and it results in tissue proliferation. And what you'll have is you'll have an inflamed proliferating synovium, which is called pannus, and sometimes you'll see that on an X-ray, and it will invade the cartilage in the bone. And eventually, over time, the tissues will scar, and you'll end up not being able to move it, and you'll end up with tendon contractures and permanent disability. So more specifically, this is spelled out in your textbook. I'm going to really skip this because I only have 50 minutes. But you can see there are T helper cells. There's a number of different factors here, and you're going to end up with damage due to these positive feedback loops. So there's a review article in New England Journal of Medicine. It has beautiful pictures and slides. Talks about the multi-step process. So if you ever have to do a presentation on RA or want more information, I recommend to look at that. But some people learn better by photos or pictures. So I wanted to just show you what happens. We have something that causes the genetics of a person in a immunity system to actually cause the dendritic cells to act on T cells and eventually recruit these cells to have this immune response, ending up in joint damage. From there, what happens is these T cells are produced in the lymph nodes and head off into the synovium, and they activate B cells, which then cause production of rheumatoid factor autoantibodies. They also activate the fibroblasts in the macrophages to release different cytokines. And you can see tumor necrosis factor, prostaglandins, and nitric oxide. So our targets, the drugs that we're going to talk about today, are tumor necrosis factor inhibitors. Our tumor necrosis factor inhibitors, main ones are adalimumab, etanercept, and infliximab. And they block the release of this tumor necrosis factor and hence cause a positive response. And we have another drug called abatacept that acts a little bit earlier. So, pathophys out of the way. It's an autoimmune disease. The body is attacking itself. So how is our patient going to present? It's a very insidious process. It's not like gout. Gout usually happens within 12 to 24 hours. You have this beefy red joint. In RA, what we see is, over time, we'll see joint pain and stiffness. Patients will wake up in the morning, find it difficult to get out of bed. They might have pain primarily in their hands and in their knees and in their feet. But the hips also and the elbows can be affected. Over time, you'll see fatigue and weakness. People are thinking, oh, well, I have this all the time. Do I have RA? It's a significant fatigue and weakness. And what you'll see is loss of appetite and sometimes a low-grade fever. And then what you'll start to see is you'll see symmetrical affected joints. So in OA, we'll have one right side, one right knee or a left hand. In RA, it typically is symmetrical. Both hands, both knees, both feet. And over time, what you'll see is joint damage later in the disease. And eventually, if you don't treat the disease, you will see rheumatoid nodules. And I'll show you some pictures of these. And they occur at a risk of about 20%. They're mostly in the elbows, forearms, and the hands. The other unfortunate situation is we can have extra articular involvement. And the specific areas that can be involved are any part of the body. So typically you'll see dermatological changes and ophthalmic changes. And what happens there is you'll have scleritis or inflammation of the sclera. We can also, they'll have pulmonary fibrosis. We can have cardiac disease. We can have pericarditis due to RA. And the other big issue in RA patients, 25 to 50% of them will die due to heart disease, and the primary reason is because of this premature atherosclerosis or hyperlipidemia will develop in these patients, and so hence they'll be more complicated than our normal patient. And you can see down the right side a number of other body systems that could be involved. So I wanted to just point this out. The most common areas that are affected in RA, I mentioned, are the hands and the feet. And on the right side is your OA. So your OA, you'll see the neck, the back, and the hands, knees and hips. But again, you can also have the knees, elbows, and shoulders affected in RA, but not as common as with OA. And this is what happens to the joint. The joint, actually, in a normal joint, has a very smooth joint capsule. You can see the margins and the synovium are very true to form and no alterations. In a patient with RA, look at the increase in the cartilage, and you have development of what's called the pannus, the extra tissue there, and a very irregular synovium lining. So this is what happens over time. We want to try to prevent this with drug therapy. Because if we don't, what will happen is the x-ray on your left is a patient with long-standing RA. Patient on your right is a normal radiograph. So you can see that deformities that are permanent and cannot go back to normal unless you have surgery. This is a patient with deformities of prolonged standing RA of the hands. You can see the contractures, and they will end up not being able to move their fingers. And these are nodules that are formed. You can see on the elbow and the hands. People will develop changes on their fingertips and the permanent disabilities that you see in long-term RA. So we want to prevent this. We want to diagnose it properly and avoid this problem. So what we're going to do is, we have a patient that presents with the symptoms. We're going to work that patient up. And the first thing will be the appropriate labs. And the labs that are used in RA are listed there. The first one is the rheumatoid factor. Rheumatoid factor actually measures the antibodies against the FC portion of immunoglobulin. And in general, a positive rheumatoid factor is 1 to 80. And most of us in this room, you wouldn't be able to measure any rheumatoid factor. It would be undetectable. Greater than 180 is called a positive titer, but what we know about rheumatoid factor is it is nonspecific to RA. So there could be other diseases that have also show up as a positive rheumatoid factor. So a big hint in a patient with rheumatoid arthritis, their rheumatoid factor is usually 1 to 320 or 1 to 640. So it's much higher than these other diseases. So lupus can have a positive rheumatoid factor, and I could go on. But your rheumatoid factor in these patients typically is greater than 1 to 320 or greater than 1 to 640. All right? So that's one key point. You can see that 80% of our patients have it greater than 1 to 320. And if a patient has a low rheumatoid factor, they still might end up being diagnosed with RA because the disease waxes and wanes. So it might have a flare, and then it'll go into remission. You might have another flare, and it goes into remission. And remember, a few slides back, I said it's an insidious process. Well, that's just what that means. Over time, eventually, the rheumatoid factor will be at 1 to 320 or higher because it's not going to die down. It's prolonged, and it continues on full force. One of the bigger ones that we measure is what's called ACPE, antibodies against citrullinated antigens, or anticyclic citrullinated peptide antibody, or anti-CCP. Same exact tests, just a different name. And these typically are found positive in 80 to 90% of our patients. And a strongly positive is greater than 60, but anything greater than 20 is found to be a positive test. I don't know what the people here, the other faculty members do here, but I don't expect you to be able to diagnose rheumatoid arthritis. All right? So I might ask you what labs are used, but I will not ask you to diagnose. That's above and beyond. Because everyone that is even suspected of rheumatoid arthritis should go to a rheumatologist, because it's a specialist that deals with rheumatic diseases, and this is such a highly specialized disease that you need to see a rheumatologist. There are other less specific labs that are always run because this will tell us the severity of the disease, and they're also used to help us make a definitive diagnosis. So we'll look at ANA. Again, this is another thing that is not very specific, and you'll see this in other diseases as well. You'll look at the SED rate, because the SED rate, if you have active disease, will be high. And you'll also look at C-reactive protein. It serves as a marker. And we sometimes use C-reactive protein to see if the disease is getting better. And finally, most of our patients will have thrombocytosis or high platelets, and they'll also have anemia. And they'll have a low hemoglobin, and they might require iron therapy. So there are two key groups that are involved with rheumatoid arthritis. And this is the American College of Rheumatology and the European group, which is called EULAR. Both have different recommendations or guidelines, and we'll talk about those shortly. But they have developed this diagnostic criteria. This is a joint thing where they work together, and they have said that we need a score of 6 out of 10 for diagnosis. And they use these criteria, and on your handout, you can see how we use those. We count how many joints are involved, we count how many positive serology tests we have, and we looked at the acute phase reactives. And I think I have the chart that we use, and we take each of these and we add it up. And if the score gets up to greater than 6 or greater, then we end up with a positive diagnosis of rheumatoid arthritis. So since that time, we also have an issue of people that might end up with a score of 3 or 4. So they come in and they have some positive lab work. And they have maybe early changes of their joints. And they might have the total, the pain in some of their joints. They are actually diagnosed with a term called early RA. And so now there's actually work being done. Many rheumatologists are seeing these patients early, trying to decide what to do with them. So some of them are being put on lower doses of the agents that we'll talk about. And I don't have time to go in. Early RA is another hour lecture. But I just want you to keep in mind, you can see a patient with early RA that might not meet these criteria, but rheumatologists are still deciding to treat them because of the long-term disabilities. The other thing is we're going to do a functional classification of our patient. Our patients are going to range. You might have a patient come in, I've seen these patients with RA, they're in wheelchairs. They can't do anything. They have to be totally taken care of. Most of them can take care of daily activities, but sometimes they're going to have restrictions. And so this is important because why do you think this is important to use in talking about how we're going to treat a patient? Anybody? So, for several fold. Number one, we use a lot of injections. So if we have a patient that has contracted hands, we're not going to be able to teach them how to give injections. So they might have to have another person at home. The other thing is if I already have a patient that has so severe disease that's restricted to a bed or wheelchair, how much benefit am I going to get from therapy? So I'll get some benefit, but primarily pain relief, but what am I going to change? So we're going to have a conversation with the patient to see what kind of goals we're going to set for him or her. So our main thing is, it's symmetrical, it's inflammation in the joints, but it can involve other organ systems. So, goals of therapy are early diagnosis. The sooner we diagnose it, the less permanent damage we'll have. And the other thing is, we want to reduce the probability of this going to joint damage because eventually it will. You cannot cure this disease. It's not curable. And it will progress over time. So we want to control this disease. We want to alleviate a patient's pain and maintain the joint functionality and maximize the quality of life. So all of those are important, and we're going to combine that into the appropriate therapy for the patient. So what we're going to do, and on your handout, where is my handout? Yeah. On your handout, you'll see some key points in treatment. And what is important there is, first of all, proper diagnosis. We're going to differentiate between gout or septic arthritis or infections, making sure the patient doesn't have lupus. We're going to look at the patient's functional status, and then we have to use assessment tools. There are a number of assessment tools. I've listed some of them, but there's actually over 30 assessment tools, easily. Everyone makes up their own to have a new name for themselves and become a full professor. So you'll see these, and then we also have different criteria or outcomes to assess efficacy. The criteria to assess efficacy, the primary ones used are the ACR 20, 50, and 70. Those are defined on your handout, and you can see here some of the scales here. The ones that I would tell you are the most appropriate or reliable is the Clinical Disease Activity Index, all right? And the other one is the Simplified Disease Activity Index, which is not on here. But the Clinical Disease Activity Index is a similar type 1 to the Simplified Disease Index. The DAS, the ones that are on your handout that are the Routine Assessment of Patient Index, those poorly correlate to clinical disease, so people are getting away from using them, and they're very cumbersome. So to do these effectively, you have to have a rheumatologist that knows how to use these tools and assess them properly. All right, so we have a number of tools. The two best ones are the Clinical Disease Activity Index and the Simplified Disease Activity Index. And then you have a number of terms on your handout that specify the outcomes, and basically that tells you how much improvement you have had. So an ACR 50 or an ACR 70 means 50% improvement or 70% improvement. But you can see we go from 20, 50 to 70 because just to get the 20% improvement in some patients is helpful, and we don't always get that improvement. So moving on, we need to have a knowledge of if there's any non-pharmacological therapy that will help these patients. And the biggest one is rest. Patients will benefit from a less stressful lifestyle. They will take longer to get moving in the morning, so they have to adjust their occupations as such. And over time, once we get their disease controlled, they should be able to function properly. I've known pharmacists who have had RA, still have RA, diagnosed with RA, and they go on the injection, and they have flare-ups. So there's days where they have to stay at home and primarily sleep the whole day because they're that exhausted. So there's this intermittent piece about it. You need to reassure patients that rest will help them and that this is something that they should expect. The other thing is if we have damage to the joints or sometimes a lot of pain, physical therapy can help. Over time, you might need assistive devices. Weight reduction will help some. It's not as significant as what you see in gout, but weight reduction will help that stress to the joints. Keep in mind that we need to have something available for short-term pain relief, such as NSAIDs or narcotics for those flare-ups. And finally, eventually, the patient might require joint surgery. So our standard symptom control is to initiate these DMARDs. Once we make the diagnosis, DMARDs are started within that first 3 months. So we do our workup, we're going to talk about, we've done our workup, we made the diagnosis, then we're going to initiate the drug therapy. And DMARDs will not act immediately, so we're going to have some symptom control until the DMARDs begin working. So we have two different groups. We can use the NSAIDs or we can use corticosteroids. Corticosteroids are very nicely reviewed in your textbook, and we can also use this for short-term flare-ups. And this is called bridging or bridge therapy. It used to be, before you all were born, most of you, it used to be that the only drug that we would use for rheumatoid arthritis was prednisone or steroids. That was the only drug we had. And there was a lot of, obviously, long-term side effects with it. It works very, very well, but now we only use it for bridging therapy. And patients, unless they're older patients and nothing else works, we don't want to use long-term therapy with steroids, all right? And we use low dose, which basically is less than 10 milligrams per day of prednisone. That's typically what we would do. And our goal is to do a tapering type regimen and get them off of the prednisone so that they don't have to be on it for life. All right? So it's very effective, and the problem is there's too many side effects with it. And it's not as effective as the other agents that are more specific to the mechanism of action or why the disease is happening. We can do injectable steroids. Injectable steroids are great for flare-ups, and I put this in here because I found over the years that there's nowhere that pharmacy students get injectable steroids, all right? So these are the ones that we use. You can see the potency listed and how long it works. So most rheumatologists like to never use the hydrocortisone because that doesn't stay around long enough. We either use the methylpred, but technically the betamethasone or the dexamethasone are the two that are preferred. We typically don't like to give more than several injections per year, and most of the times we wait at least 3 to 4 months before giving another steroid injection into that joint. So this again is just to provide symptom control because that patient is in severe pain and they're having a flare. And we could inject it into more than one joint. Okay, so treatment options. So on your handout, you'll see non-pharmacologic therapy, and those were the assisted advices, sometimes TENS units. Wax baths actually can sometimes help the patient. And then the other thing is pharmacological therapy. In our RA treatment, we are going to use disease-modifying anti-rheumatic drugs, or DMARDs. And there are two different classes, the non-biologics and the biologics. And here you'll see listed the DMARDs. Our non-biologics are over here on the left. The drug of choice is methotrexate. But any of these agents are used. Methotrexate is the primary drug of choice. It's used in a much different dose. It's used once weekly. And all of them have toxicities, but this is the drug that we primarily use. On the right side, you'll see all the biologics, the tumor necrosis factor inhibitors. The box that you have there has the brand and generic names listed here. And then down at the bottom, these are the newer agents that we have. They're non-tumor necrosis factors, and they're listed on your textbook. And these are available as well. These are not first-line agents, all right? So our first-line agents are going to either be a non-biological drug, primary agent methotrexate, although we can use any of them, the hydroxychloroquine, leflunomide, sulfasalazine are ranked above minocycline. Minocycline would be your last drug of choice. The tumor necrosis factors, all of them listed here, would be another first-line agent. They are all interchangeable. However, if you look at them closely, there might be slight difference in efficacy, but very slight. Probably the one that has the least efficacy is golimumab. Golimumab is the only agent that actually has methotrexate required to giving concurrently with golimumab, all right? And the reason for that is all of these agents will develop, the patient, once they get these agents, they can form antibodies. And they form antibodies to the tumor necrosis factor. And by giving methotrexate, we can avoid the formation of antibodies over time. So golimumab requires methotrexate. Most of the other ones, we'll talk about shortly, give concurrent methotrexate as well. So, if If we fail one agent, we can also use combination therapy, and I'll talk about that shortly. So the other piece is we can use more than one agent, but key point, very important for you to remember, you're not going to use two drugs that have the same mechanism of action. So I'm not going to put him on, if he gets diagnosed with RA, I'm not going to put him on two anti-tumor necrosis factors. So he would not be on Humira and Enbrel at the same time. You could be on hydroxychloroquine, sulfasalazine, and methotrexate at the same time because they have different mechanisms of action. And combination therapy has actually been proven and shown to have a better response rate if a patient fails single agent therapy. So, we're going to choose based on the convenience of the patient. If, they're working a lot, they might not be able to take something 4 times a day. We're going to look at cost and toxicity and adverse reactions because that's going to affect compliance. And the biggest factor that the biggest factor that's going to have an impact on your outcome is going to be compliance. So the patients really have to be compliant. And we will only have about a 50 to 60% response rate. So we don't always have a response, and there's going to be failures despite even patients being compliant. So we have to look at this and evaluate it constantly. So on your handout, you'll see DMARDs. You'll see the biologic agents. What are our black box warnings with the biological agents, particularly the tumor necrosis factors? All biological agents have the risk of infections. You have to really watch the patient for the development of tuberculosis, and you also have to watch for fungal infections. The other big risk is the risk of cancers, primarily lymphomas. All right? So if your patient is at risk for these, you may or may not pick a different therapy. All right? We have also contraindications. So originally I told you that rheumatoid arthritis patients are more at risk for cardiac disease, but they also, you have to beware that DMARDs, you have to really use caution if they have moderate to severe congestive heart failure, because DMARDs can worsen their disease. And if a patient has multiple sclerosis or optic neuritis, that can also be a contraindication. So I'm kind of simplifying it for you because there's so many drugs to learn. If you remember it overall, that the biological DMARDs all have these risks, then it'll be easier for you to remember. And the other thing is remember that they're active agents and they're biologic agents, so you're going to have to give all your immunizations beforehand. And you're going to have to assess a PPD test beforehand to make sure that your patients don't have that risk. And so our common adverse drug reactions to all the biological DMARDs are infections as well as allergic reactions. And some of the allergic reactions require pre-treatment, and they can actually cause you to die from allergic reactions if you don't treat them appropriately. So we give live vaccines prior to DMARDs, and we also check PPD tests. So posted on Blackboard, is that what you use? Posted on Blackboard were a document that contained the 2 guidelines, the ACR guidelines and the EULAR guidelines. You have that as a separate document, and I added them to the slides. So there's 2 pieces here. They're a little bit different. I'm going to walk them through you, and you're going to sit there and not know what's going on because I haven't covered the drugs yet. But because I only have an hour, 50 minutes really, I put all the drugs at the back of your handout, and I have slides on all the drugs. So what my next goal in 10 minutes, I wanted to give you a very firm foundation of the disease. And my next goal is to go into just briefly looking at the guidelines, walking you through them, and then doing the cases right after this with regard to the patients. All right? So, our first thing in general, on your handout you have, on your handout, what you have is, I thought I could be fast. You have a schema. And this is the schema that you have. Okay? This is a very general schema of how we're going to treat these patients. You have disease activity, you have destruction over time. You're going to use any of the DMARDs, and in between, you're going to use nonsteroidals or analgesics or prednisone to minimize that disease activity and pain until that patient is controlled and these other drugs kick in. But our guideline comparisons are driven, are a little bit different. There's also Canadian guidelines, but they all start the DMARD early and they don't have a specific agent. Okay, so the two comparisons, they prefer methotrexate with the EULAR, but basically all of them say if you want to, you can use an anti-tumor necrosis factor or you can use methotrexate. These are the ACR guidelines. So you're going to look to see if you have high disease activity or low disease activity. And based on that, this is early RA, you're going to use DMARD either monotherapy or DMARD triple therapy or double therapy. All right? Or you're going to use an anti-tumor necrosis factor with or without methotrexate. This is late RA. In late RA, you look at low disease activity with poor prognosis versus moderate to high disease activity, again, monotherapy or combination therapy. And you'll follow that, and they can reassess and change therapies as appropriate. And the same thing goes with the EULAR. The EULAR, actually, the big difference here is they make a recommendation of combining it with prednisone up front and a preferred methotrexate mono versus the oral agents of leflunomide or sulfasalazine. And then with achieving the target by 6 months and then adding on other therapies. And if you have failure, where do you go? So, I've never gone through this as quickly, but I think your key points are to realize that there's guidelines, to realize that you start with the DMARD as soon as possible, within 3 months or sooner, all right? And then decide what to use, what is appropriate for by talking to your patient. There's also this brand new target to treat strategy. I gave you the link, but this is basically what we're doing, and this is the general goals of our therapy. We want a clinical remission. We might have to settle for low disease activity. We might not be able to get this patient totally into remission. So LDA is acceptable if that's what happens. And patients have to know that. But the biggest thing is we want to adjust our therapy every 3 to 6 months. So if my patient isn't responding in 3 months, I'm going to make a change. I'm going to monitor that patient monthly. Every month that patient is coming in, and I'm going to assess them. And if they don't have changes in 3 to 6 months, I'm going to change their therapy or add something on. All right? And you have to make sure that you use the proper measure of disease activity. You have to have a desired goal. All right? And finally, you might have to not be as aggressive in certain patients, because certain patients are going to have more problems. They might have chronic infections. They might have side effects from the drug. So you're going to have to back off a little bit. So we can't, this isn't like curing pneumonia, all right? It's not like treating hypertension. we really have to be careful in how we address this. So, most people begin with methotrexate. Steroids are short-term, and you will see that most people will start with a dose of methotrexate of 15 milligrams to 20. In some of the textbooks, you'll see 7.5 listed once a week. These are all once weekly doses. The other key point about methotrexate is that you must give it with either folic acid daily or folinic acid once a week. All right? Because people will end up with anemia and they'll have more toxicities. And the other thing is we could use hydroxychloroquine. And if we have an unsatisfactory response, we will add a tumor necrosis factor. So that's a general rule of thumb that we use. Combination therapy works really well, and but we don't use it up front unless we have really, really bad disease. But we basically will add new drugs to methotrexate, and they have shown to be added efficaciousness. If you wanted to pull a trial that was one of the first ones that did combination therapy, you can see methotrexate, sulfasalazine, and tapered high-dose prednisone, or methotrexate plus infliximab, or a combination of 3 DMARDs. But I wanted to show you this. 52% of only 42% of your patients ended up in remission. So this isn't a disease that we're going to have responses in everybody. But just if we can get a 20 to 50% response, that can improve their quality of life. So triple therapy is an option. And I wanted to point out using the biologics with or without methotrexate. First of all, I mentioned golimumab. It must be given with methotrexate because of antibody production. Etanercept, the studies have shown that we increase the response rate of about 20 up to 20, from 40 to 45% up to 60 or 70% when we add on methotrexate. So there will be some rheumatologists that want to start out with both together at the same time, but a lot of rheumatologists will start out with etanercept, and then once we start to see that patient lax off or have a problem after a years of therapy, then we add on the methotrexate. And the studies have shown by doing that, we can have the same response. Okay? The other thing is that adalimumab in early RA compared to methotrexate in early RA, people say, which one should I start with first? Well, actually, both of them have a similar response over time. So a patient might say to you, which one is better to go with? As long as they're compliant and we monitor them closely, both of them, as long as they're dosed appropriately, will have similar responses. And finally, this last one, tocilizumab, actually has better results without methotrexate. So that's another agent that just came out, and that is showing a better response without methotrexate. There also in the New England Journal is tafasitamab, which is a JAK inhibitor. It's an oral agent. Shows great responses, but should we use a JAK inhibitor as our first-line agent when they have such serious toxicities of infections? Okay, so people will ask about that as well. So controversial, and the last thing is, can therapy be stopped or decreased? It's a judgment call. Most of the studies, there's a few out there that have shown you might be able to decrease the dose by 50%, but if you stop the therapy, the disease will come back. A lot of women, obviously, that are on these meds and want to get pregnant, they have to talk to their OB guys. Most of us try to have them stop their therapy, and they only go on the therapy if they have a significant flare. Obviously, we couldn't use methotrexate. We would have to use one of the tumor necrosis factors. Okay? Now, I mentioned comorbidities. Cardiovascular disease causes half the deaths. We have an issue of infection in these patients, and we have the risk of malignancies. And the last one we have is osteoporosis due to increased osteoclast activity. So we have to monitor the patient for all of these. We have to manage the blood pressure, the cholesterol, and the smoke. So your responsibility is proper drug administration, compliance, pain control, your immunizations, and make sure the TB testing is done. So, I have some cases. I can't get to them. I apologize. I want to just, I have two options. I've actually made Panopto videos before for the students when we had, last year we had like 5 snow days. If you would prefer me to do it in a Panopto video and walk you through that, I'd be happy to do that if you're able to post those.
Sure. I'll have to ask Adam. What's the name of the tip?
Or it's a Panopto video. Or, okay. I mean, I could do that for you, or I'll just post a written document. It's not the same, but if you, this patient here, I'm just going to just do one case real quick. So here's a typical patient, and she is diagnosed with RA. If you look at this, what do we need to diagnose her? We would look at number C. C would be our acceptable thing because we want to be able to evaluate everything. We have to have that score be 6 out of 10. We're going to need all those factors to be able to diagnose her. Her classification would probably be a 1 or 2. And on the score, on the Simplified Disease Activity Index, she scored 10 points. This would put her at moderate activity. And when should she start therapy? Should she start it in 2 to 3 weeks? Or not? So she should start it as soon as possible. Your only thing you have to make sure about is her vaccines are up to date, her PPD test is up to date, and she has no contraindications. So any other labs, our biggest thing is we're going to use methotrexate, and your slides are such, they have all the information you want to know, but we're afraid to ask. And the medical letter handouts contain a lot of information. So methotrexate, you'll see it. I have 7.5 milligrams once a week, but most people start with 15, and you really have to monitor the patient, and you want to minimize toxicities with methotrexate. So I can't stress enough, you need folic acid and you need leucovorin, okay? And they're not the same, they're different doses, but that's to avoid the bone marrow suppression, all right? And there are contraindications and concerns and drug interactions. Sorry I couldn't get through everything, but I wanted to give you the key point about rheumatoid arthritis. So good luck, email me, and have fun. I mean, I'd be happy to make the cake, and then you
Can you maybe take pictures of this? See ya.
Oh, okay. Well, I think if I do occasionally, they understand that I can't.
See, that's why I didn't know you liked it.
So I really try, it might be easier just to get the cases.
Okay. Great, because I'm definitely not a great expert.
See, my problem is when there's so much about it.
No, it's when you start to know something
And I,
you want to tell them everything.
and I know they don't need to know that sometimes is